Casamba is the largest provider of therapy management solutions in the post-acute space. Through our smart direct bill therapy source rehab toolkit and HealthWise solutions, we now serve over 10,000 locations across the country, including skilled nursing facilities, home health and hospice organizations, and of course, outpatient therapy clinics. For those of you that are new to our webinar series, I'd like to introduce our host today. For those of you that have been with us before, his voice will definitely be familiar to you. So David McMullen is our Vice President of Products. He's a licensed physical therapist with over 20 years of experience in a variety of healthcare settings. David was integral to the development of Casamba's recently acquired TherapySource software. And you may also recognize his work from various industry publications and presentations, including PT in Motion, the Journal of Physical Therapy, and Health Data Management. So with that, I will turn it over to David to get us caught up on the latest regulatory news and updates. David?
Thank you, Megan. I appreciate that. Thanks, everybody, for joining, and I want to wish everybody a very happy and celebratory early July 4th weekend. I hope you have exciting plans to get out and enjoy the summer and the weather and fireworks and all that fun stuff. That's going to be probably a whole lot more fun than maybe a lot of the stuff we're going to cover today. So I hope you have good plans. Quick review of what we're going to try to cover, and there's actually quite a bit of content. So the great thing is we are recording, and we will make the deck available. So if there's anything that I go over too fast or too quick, or you need more detail on, please reference those materials for sure. The other thing I always like to say and cover off is, you know, no matter what, I'm just one therapist who does a fair amount of research, attends conferences, attends numerous things, reads a lot of the regulatory information. I always want to point you to the source of truth, whether that be CMS sites. Always do that. You know, there's too much stuff that gets misinterpreted, and it's a hard enough time even CMS interpreting their own rules sometimes. So, you know, great reference, but use the resources and the references to get, you know, you'll see exactly where we're pulling stuff from, and the references as your true source of truth. So we're going to cover the ICD-10 changes that are coming in the fall, a little update on quality, both on the MIPS and the alternative payment models. We've got a new fee schedule coming pretty soon, so the proposed fee schedule, we'll talk about that. I wanted to cover some of the legislative things going on. I know it's been kind of hectic and crazy with the new administration and a number of things, so we'll cover updates on several of those items, particularly as they pertain to us in the rehab space and PT and OT. I would be amiss if I didn't talk a little bit about the ransomware and malware things that are going on. As early as this week, yet another attack is significant. So what does that mean? What does it mean to us in healthcare, and those of you leveraging technology in healthcare, et cetera? A few other just regulatory updates to kind of just be aware of. I want to cover off. There's some good news, and then some of the additional webinars we have planned for you to keep you in the loop on a number of things coming forward, and then obviously the resources and references for you to be able to utilize. So with that, let's kind of jump into the ICD-10 CM changes that we know that are coming. So there's the codes got released on the 24th of June. There's not a significant amount of changes, so there's 71,486 codes. Not a big jump. As a matter of fact, it's, you know, slightly less from the codes before. So that's a good thing. We had a huge change last year, as you remember, because the freeze came off, with the transition from 9 to 10. So we had a whole bunch of additions, changes, revised codes, etc. last year. So this is a little bit getting more back to normal with code changes. So there's not that much overwhelming and consuming things to be concerned about. There's still more information that will be coming. So, and keep in mind, these codes don't go into effect until October 1st this year, and then they'll run through, you know, the changes and the revisions and the deleted codes. All that is not in place, or those codes are not effective until October 1st. I want to make sure you're aware of that. from a resources perspective, there's a whole bunch of coding information, the descriptors, the tabular order, the tables, the index, the addendum are all available, and I put the links there. The link is also in the resources thing to be able to go to the CMS site and pull that information. The only thing that's not out yet that will be coming out is there's really good detailed addendum documents and the guidelines document, which is another really good reference point. Those aren't published yet. They should be coming in August based on history and what we're hearing from the CDC and stuff, and those things will be published. And I'll be keeping you guys aware of when I see those go out. If you follow me on Twitter or through our blog or other social sites, you'll see, we'll make sure everyone's aware that those are there. So more specifically to as an outpatient in our space, let's talk about, okay, it's a whole bunch, more codes or see these new codes. So what does it mean to us? So I kind of just took the code set, looked at it and said, okay, well, how many are new, how many are revised, how many are deleted? So there's 360 new, but when you look at the M chapter and the S chapter, so the injury chapter and the musculoskeletal chapter, so the musculoskeletal chapter, the M chapter, there's only 5 new ICD-10 codes. So that's very easy to manage. There are some new codes around and changes around spinal stenosis in the lumbar region, which is pretty can be pretty heavily utilized. Keep in mind of that. And then on the S chapter, the injury chapter, there are actually no new codes. So for that 360, there's a whole bunch of codes relating to cancer and blastomas, a lot of new cardiac codes. So if you're in that more inpatient setting or cardiac rehab setting, you may want to be aware of those, but sure, outpatient orthopedics, not a lot of new codes to be looking at. Then there's 226 revised codes. So revising from a certain code now to a new code, it's got a change to it. So again, there's 8 revised codes in the M chapter and 176 revised codes in the S chapter. A big chunk of those revisions are around, for the S chapter, are around the hand, finger, thumb, and digits of the toes around fractures, subluxation, dislocation, etc. That's a huge chunk of that 176 that got revised. So again, not significant in changes, but you do want to take a look at those specifically. And then there's 142 deleted codes. Again, only 1 deleted in the M chapter, but there's 108 that are deleted in the S chapter. So look at those because those will no longer be effective codes come that October 1st date, and you do want to make yourself aware of that. From making sure we're doing a lot of comorbidity stuff, I did not include this specifically on the slide, but there are some changes to some of the diabetes codes. So you may want to look at that. Always make sure you're looking at those other areas where we're trying to document and add particularly some of the comorbidity diagnosis codes and related codes to our patients. So, those are things I really encourage people to, don't just be considering those code changes as well when you're looking at the code set and the changes that may be occurring. So with ICD-10, I said I didn't put a lot of content in here with respect to this, but obviously, what do you need to do to prepare? Well, just review the code changes and the potential impacts to your business. You know the types of patients and the patient populations you see, whether that's pure orthopedic or if you do a lot of women's health or if you're doing lymphedema or if you're multidisciplinary, PTOT and speech, those are the things that it's really look at the code changes and the impacts to your business is a really good thing to do. And then prepare from a software or system upgrade. So not knowing which system you're using, if you're using our system, you're using somebody else's system, it may require you to get an upgrade to get all the new codes in place. So, be prepared for those or schedule that and what changes you need to make. The changes we've already made to our system and those code changes are available. You'll be hearing more about that for those of you who use our software. But again, just make sure you're getting that in place and understanding, and also make sure that whatever your system, if you're loading the new codes, that your system has some capability to allow you, so you're not selecting those new codes until they're effective. And the same thing is make sure you have configuration in your system, especially to make sure you can't select the deleted codes after October 1st, so you don't run into coding and editing edits that are a problem. With the new codes, some systems you have the ability to add your own keywords or search criteria, particularly if you see they're heavily used codes in your space and in your business. So you can be planning just around that. And it's always good to educate your staff on all regulatory changes, but new codes, particularly those that you do, are constantly using. And again, not just from the orthopedic perspective or the pure outpatient perspective, but some of those comorbidity diagnosis codes and changes that you want to make sure everyone's aware of. Really keep your team educated on those types of things. I always recommend that someone in your organization or structure, is really good to read and review the guidelines when they're posted, because it really provides a lot of value and content for you to prepare for the changes that come. So again, we'll keep you in the loop on that. Be looking for that. Probably going to be sometime in August when those are posted and made available. Either the CDC will post them and then you'll see them on the CMS site, et cetera. And then obviously from a diagnosis code changes, you always want to be able to prepare for any changes that may impact medical necessity and LCD edits. So as you get into that fourth quarter where, that October where the diagnosis codes are available and then they're effective, the new ones are effective and the changes are effective that month starting in October, what changes to LCDs or medical necessity edits could be in place that you need to be able to prepare for, whether from your billing staff and or your clinical documentation adjudication. So just want to make sure. So with that, let's talk about quality. So this is an ongoing big topic that continues. I will tell you, I get a lot of questions from folks with all the things going on and with the new administration and legislatively, and we'll talk a little bit more about the House bill that's in the Senate and et cetera. But are all these quality programs are going to eventually are they going to get killed? Are they all going to get taken away? What happens if there's a certain amount of repeal to the Affordable Care Act or Obamacare? Will this kill all these things? This isn't going away. The quality programs are generating enough savings and benefits. So this thing's still marching ahead, regardless of what's going on the Affordable Care Act or Obamacare. So don't think that all of a sudden all the quality initiatives we've seen in the last several years and continue to see are going away or you can ignore. So when you look at the evolving payment system that so many of you are kind of familiar with, we kind of live in, I know it says payment past, payment present, payment future. We're kind of some of the past and some of the present. So obviously we're still using functional limitation reporting. There's still some manual medical review. There's quite a bit of still fee for service, but at the same time we have these new eval codes, the complexity-based eval codes. We have more outcomes-based payment that's impacting us, and the alternative payment models have been evolving for the last several years, and they're continuing to add more. So we're kind of in that hybrid between the two. And we know the goal is to get to an episodic payment, based on meaningful outcomes. And so we may not get there for a little while, but there's still some mandates definitively to get there. So those changes have been somewhat painful and will continue to be, and we just need to keep, real awareness because of the impact to the care we deliver, and our financial responsibility and revenue impacts to our organizations as we move forward. So this is a slide that it was really kind of gives you a whole little scenario just of all the quality programs, under Medicare and the Impact Act, based on the healthcare setting, the reporting level, et cetera. So as we know, if we look across the top, the alternative payment models across all settings, the keys are looking at, what's the reporting level and, how these programs, they continue to add what I call more alphabet soup to healthcare and healthcare IT with some of these programs, but what's an episodic, payment model, bundled payment model versus, more of an ACO model, and how are the costs or payments or incentives and penalties tied to each of those. So as you can see, there's alternative payment models go across a number of the different settings, and we've heard about the CJR and the cardiac bundles and the hip fractures, et cetera, and then the ACOs we're familiar with, Medicare shared savings programs. Then the Impact Act really, significant what we're doing with the post-acute care and getting all the quality measures standardized across the LTACs and the inpatient rehab, the skilled nursing, and home health. And then down on the outpatient side, we're still familiar with the ongoing functional limitation reporting at the patient level. And obviously, the successful reporting is a condition of payment right now. And then what was PQRS, and now we're doing MIPS, both on the individual and group level, where MIPS started in 2017, not required by us, but a number of you I know who are reporting PQRS are continuing to report those quality measures under MIPS, and that's, again, a value-based thing. So we'll continue to see this evolve as we move forward. From a timeline perspective, just to kind of pull back to a 10,000-foot level. So we started these CJR models, and obviously in 2016 was kind of the last year we were recording PQRS measures, and then the results of that recording of those measures, we'll see the impact of that successful reporting or not next year in 2018. And then in 2017, we had MIPS kick off and start that we were, from a voluntary perspective for us, and there was a number of different programs in which the physicians could participate in that. The cardiac and hip fracture models, some of them were delayed due to some of the changes in the administration and some of the lack of preparedness for the quality programs, but those are back sort of underway. Again, 2018, we see MIPS as still being voluntary, but 2019 is when we're looking at, you saw the IMPACT Act, you're going to get standardization of the post-acute care measures, and the data, and then MIPS, may become mandatory at that time for us in reporting and providing that detail and information and those components. We'll talk more about MIPS in detail a little bit later. And then as we talk about the transitioning of the overall healthcare or payment and quality, how much more progress are we going to make toward the new episodic payment model will determine. As you know, from a standardization of measures, we're all over the place in outpatient, where there was much more standardization in the post-acute care space than in the pure outpatient space. So we got some work to do there, and those things are ongoing discussions. So as we transition, to that value-based payment, model, we know healthcare is shifting across the board, right, with the large hospital institutions, physician practice systems, with all the APMs and MIPS, and those mandates are still continuing to move forward. We're seeing more of these, alternative payment models pop up in different areas and different specialties, and they're providing real value and reduced costs. So the models are all built around sort of quality and performance and patient satisfaction and patient criteria, as well as the financial and accountability. All of the alternative payment models, they include both physician-focused models as well as the advanced alternative payment models that we'll talk about as well. The thing that I think we need to continue to remind ourselves is we're, is kind of looking at shifts in the quality from an individual reporting or data analysis versus a population. So there's a number of things we look at as how am I doing as a therapist or this particular type of patient, and how is that compared to the other therapists or this patient as a whole? How do you treat this condition across a broad population, and where does your practice, how do they measure up from a benchmarking perspective? We've heard this say numerous times before throughout our industry, but more and more in not just healthcare, but specifically to outpatient rehab and PT, OT, and speech. Data is the new currency, right? So the better you can have data, and one of the reasons for the big push and initiative by the APTA and the new outcomes registry they launched and are continuing is the amount of data they're going to be able to capture and provide will help us. And it also gives us a mechanism to be able to report effectively to some of these bodies that needs that reporting. So we'll be working with them from our software, from an integration perspective to give you that opportunity, but we really need to start looking at it. We were very narrow focused on looking at either just an individual patient or just an individual therapist, which we need to do in some, but now we're looking much more from a population perspective, and we need to start looking at data that way. So when we talk about sort of the Medicare alternative payment models, and what are they? So some examples of those are, would be, your accountable care organization, ACOs, you've heard about them, and then the evidence-based sort of payment bundle models, right? So you have the ACOs on one side, and ACOs, groups of doctors or other provider networks that share financial and medical responsibility for coordinated care, right? Some of them, have incentives of care quality over quantity. Some of them, there's no risk, smaller reward, and other ones, there's significantly more risk, but there's also bigger reward if you provide those services effectively with great outcomes and lower cost. And so that's kind of that side of it. And then when you look at the episode-based payment bundled models, it's kind of that single price for all the services bundled into the care, offers flexibility to determine what services should be delivered, reduces incentives unnecessary for service provided. So you've got the comprehensive joint, you've got the cardiac models we've talked about, and then the BCPI models, et cetera. And so you'll see more number of the organizations and details, and some of the links if you want to dive into those. And the number of you that I know and attending in some of the conferences and sessions have been participating in the joint models particularly. So it's always good to hear and get that feedback as to how things are progressing for you and whether they're working well or they're burdensome. So when you look at the payment program, so quality programs created obviously under MACRA for Part B clinicians, for Part B outpatient services that we provide. There's two ways to participate, right? So there's the merit-based incentive or the MIPS program, and there's the advanced alternative payment models incentives. So both are all part of the quality payment program, and they have different, one's an incentive payment on the APMs, and the other's definitively performance-based. So we've done, and I've been through a lot of this with you guys before as to what's MIPS and how is MIPS made up, right? So MIPS is made up quality, cost, advancing care information. And I'm putting a little note here because when you look at the MIPS and the categories, and I'll go into MIPS a little bit more specifically in a second, there is definitive reference to some of the advancing care initiatives as to whether those items will require you to be using a certified electronic health record or not, or can you simply use a qualified clinical data registry? So there's some vagueness around that. Certainly, we are in the process of becoming a certified healthcare record, which we believe in 2019 you're going to have to be to continue to be able to give your clients and your customers the opportunity to leverage either of these models, because the advanced APMs, it is required that if you're going to participate in an advanced APM, that you use a certified electronic health record. Now, if you ask me the question, well, why isn't everybody in physical therapy software already a certified electronic health record? Well, that was all driven around meaningful use, and some of the criteria in order to be certified was very onerous, and almost all of the physical therapy specific programs, none of them were certified or even tried to get certified because of the amount of data that need to be captured was very much geared toward the physician systems and the large hospital systems. So those things are changing, and it's becoming a little bit more easier and better for you as well, so that we have these certified programs available for you to be able to submit data. On the APMs, again, it's already a given. We don't have to guess that if you're going to participate under an advanced APM as a quality program, that you have to be using a certified electronic health record. The quality measures are comparable to the ones in the quality category under MIPS. And the quality category, as I said, it's really kind of your old PQRS measures. In the advancing care information under MIPS is the old meaningful use, and we'll talk more about that as well. So here's sort of the MIPS timeline. So when we talk about MIPS and in the MIPS timeline, so obviously it started in 2017, and we didn't really have to do much with that, but everybody, APTA, and we were all recommending for all of our customers and clients, if you're reporting PQRS quality measures, continue to report them this year and next year, because you're going to get data back, you're going to get reports, there's no risk and penalty to you, but it gets your therapists and everybody in the habit of continuing to report. Right now, the plan is that we will enter the program in 2019. Now, what's really important about that is just like PQRS and the way CMS runs, it always takes 2 years to be able to collect the data and the results of the data. So that green arrow in the middle is where we would be impacted by whatever we did in 2019 in our reporting in 2019. So come 2021, we'll either get a plus or minus 7% adjustment in the Medicare fee schedule based on how well we reported in 2019. So the old 0.5% or 1.5% on PQRS, 7% is significant, right? So if you look at that, what that means on a per therapist level, that could be $4,000 to $5,000 a year impact on each therapist for that adjustment when you do some of the math. So that's all under the MIPS. And then under the quality program for the advanced alternative payment models, there's a 5% bonus. If you participate in those, you don't have to participate in MIPS, but they're currently not broad enough to cover all of your Medicare patients, which ends up being a little bit of a challenge. But that timeline's pretty set. We're keeping track as to whether some of the additional providers, which were underneath the PTOT and speech, right now, everybody's marching, and we should assume that come 2019, we will be required to start reporting. So, right, it's a little bit about MIPS, so it's already started, right? Jan 1, you don't formally have to participate in the inception years. Health and Human Services Secretary has the authority to add us in 2019, so we're waiting to hear about that. The other thing is, unlike like the PQRS quality measures, really only pertain to the pure Part B and didn't include the facility-based providers. Well, everybody's saying and talking to the APTA folks and the advocacy and regulatory department and looking what's out there, I think if you're a Part B provider and you're facility-based, you should be planning that you're going to be required to report come 2019. So that will get more clarity as we move forward through the year. But that's something you should be planning on for sure. As we know that MIPS really replaces several legacy programs. We talked about the PQRS, we talked about the value-based modifier, and then meaningful use is the advancing care initiatives. But that's the new program. So when you look at the individual performance categories, quality on the left-hand side, that's what's replacing PQRS, right? And same for a reporting mechanism, or how do you submit data? You submit it via claims, through EHR, through a registry, and several of you are doing that, whether you're doing it claims-based, which somewhere around 85 to 90% of all outpatient rehab providers is currently still submitting PQRS data, or was submitting PQRS data last year via claims. But obviously registries are out there. The APTA's got a registry. Some of the other vendors have registries. Photo, a lot of people use Photo as a registry to submit that data. And that's where we're kind of participating today, and as we move into next year. Clinical practice improvements category, that's a new category. And the way you would submit data with respect to that would be through an EHR or a registry. The advancing care initiative, advancing care information category, this is the one that replaces meaningful use. And this is the one where the data submission looks like it's through an EHR. Whenever it says data submission through an EHR, if you do that, it has to be a certified EHR. Don't assume that it can be just any electronic health record or any electronic medical record, right? If that's the method of submission, it has to be one that is certified by the ONC. So, or a registry. So this is one, there's a little bit of a gray area in the interpretation, whether you will be required to report, to be using a certified EHR, even if you report these measures via registry. So there's a little bit of lack of clarity on that specific thing. So keep posted. But again, if I was still practicing and we're using technology in my space, whatever I was using, I would make sure if it wasn't certified, that they were planning to be certified before 2019, and I would keep posted on that. And then from a cost perspective, this replaces the value-based modifiers. There is no submission we have to do on our behalf. It's not applicable. It's something that's calculated by CMS themselves. So keep that in mind. So a little bit about the advanced APMs in general. So they're the advanced alternative payment models are simply just a subset of the alternative payment models, and they're used to determine Part B Medicare payment adjustments, right? The goal is to improve, again, the Medicare beneficiary, the patient's outcomes, and lower their cost. There's an incentive payment to provide high quality and cost-effective care. And so, they include the Medical Shared Saving Program, ACOs, the evidence-based payment models that we talked about, the CJRs, et cetera. They're all part of the advanced alternative payment models. And if you participate in those, you're excluded from MIPS reporting if the threshold criteria is satisfied. So that's a big thing about you have to get over that criteria or those thresholds so then you don't have to report in MIPS. And that depends on your patient population and the models you're participating in. Does the amount of reporting you're doing on the advanced alternative payment model meet the threshold such that given all your Medicare beneficiaries, then now you don't have to report. So it's something that's a little bit tricky. And then 2021, the MA contracts can help clinicians meet revenue and patient account thresholds to qualify for the advanced alternative payment models. I'm getting tongue-tied on some of this stuff. So again, why participate? Well, you will hear that MedPAC's really pushing. MedPAC would prefer people, we as providers, were participating more in this model than the MIPS model, but you can get a 5% incentive payment, right? So, and keep in mind that in 2026 and beyond, we're only eligible for a 0.75 fee schedule update. So with the big changes that were made with sustainable growth rate and the fee schedules, et cetera, these incentive payments, we're not going to get some of the good positive adjustments we used to have. And the good thing is we don't have to fear the big reductions in the sustainable growth rate either. But so this is one of the ways to do it. The other benefit is if you do it and you meet the threshold for your Medicare beneficiaries as a provider, you don't have to report in MIPS, right? So you take potentially that burden away from you. And from APTA and talking to them and some of the other organizations in AOTA, right, it's an opportunity to demonstrate value for physical therapy and occupational therapy by participating in these models. And, so the models to consider, obviously the joint model is kind of right in our wheelhouse, the hip fracture, the cardiac models, and there's other models under development. So be aware of those, particularly if they fall into your area where you can participate. And if you have a high population that it could potentially, a high population and a new model, all the more reason to be considering participating and getting actively involved. So when you compare the MIPS to the APMs, the MIPS, adjust providers' payment based on quality, meaningful use, efficiency, and practice improvement, right? It's an up or down sort of incentive or penalty. And the data submissions typically via, a qualified clinical data registry, which the new APTA outcomes registry is a qualified certified data registry, clinical registry, or other means, right? Certified electronic health record, et cetera. But those are kind of, we're seeing where the claims-based ability to report eventually is going away. We knew it was going to go away. So we need to be preparing to share data better and through electronic mechanisms like registries and like certified electronic health records. On the APMs, offers highest possible reimbursement. So you have to take on risk sometimes that's related to patient outcomes. And as we said, we know for sure if you do the alternative payment models or the advanced alternative payment models, you have to be using a certified electronic health record. That we believe that's going to be true on the MIPS side as well under that one category, advancing care initiatives, but that's not definitive. But if you go the APM model, without question, you got to be using a certified electronic health record. So kind of like what do you need to do next steps? I covered this a little bit previously. So depending on your setting, so whether it's Part A, Part B, pure private practice. So you guys have already been doing the new data elements from last year into Section GG and reporting on those. Be familiar with those. But as we get some of the new payment models coming out, et cetera, you're going to want to make sure you're staying on top of those ongoing changes. Part B, implement quality management in your practice, and stay tuned for information on provider-based stuff on being required under MIPS to participate when we get to 2019. So be keeping yourself in the loop on that. In the private practice setting, continue to submit the quality data from your PKRS because you're going to want the value in reporting to see where you are. It was good reporting. The reporting will probably be as good, if not better, under MIPS, so you can see and keep that behavior going because quality reporting is not going away, and the better we can leverage it. And then, leverage and incorporate technology into your practice to support value-based. So whether it's APMs, which we know is required, or MIPS, which it may be required to have a certified electronic health record, all of this reporting and data capture and submission, et cetera, and payment and outcomes tied to it, if you're not leveraging technology, if you're trying to do this on paper, you've got to budget and get in and be using a program to do this and be able to, it just provides you so much better data on how your therapists are doing, how your practice is doing, how you compare to your peers, and how as a global provider of, and we start trying to mitigate and go after help the opioid epidemic, having good data to support the things we want to be able to do in outpatient rehab is critical to be able to have that data. And then start looking to your costs and analyzing them and look at stuff across an episode of care. Because as we know, we move into an episodic model in payment, you want to start having a better sense of not what am I getting paid per visit, but what am I getting paid for an entire episode, and how does my cost for my practice, so as we're running that small business, or we're running that business to be able to do that. The large entities are preparing for this, right? So you want to be able to be doing some of those things. So let's talk about the 2018 Medicare physician fee schedule. So kind of a little maybe teaser because it's not out yet. So it's coming soon, probably sometime within the next week to 10 days. They will publish the proposed Medicare physician fee schedule. So some things we're kind of know or we expect to see in it. Well, let's talk about those, and some things that are probably not going to be in it that you may be worried about. We'll talk a little bit about some of those as well. So misvalued codes. You know that we dealt with the new evaluation codes last year with the different tiers, even though they had the same RVU, but those were, those changes were put in place and those tiers were put in place again because they were considered misvalued, and we started having to use those, and they're using that and looking at all the reporting tied to the allocation and how many the complexities categories and which patients are falling into which by discipline. And so I've shared some anecdotal data that we see how that's coming across today. So the other codes that were identified as potentially misvalued codes are listed there on the left, right? And there's some pretty high utilized codes by us. In talking to the APTA and some of the discussions earlier in the year with what we may see in the fee schedule with respect to some of these codes and changes and adjustments that may impact us, as far as I know, and up until last week, we're going to see some impact with that, but it's going to be definitively in single digits from an impact of payment. So we'll keep an eye on that. We'll see what comes out in the proposed fee schedule, but we're going to see some adjustment with respect because of these potentially misvalued codes and these ones in particular. Maybe not all of these will be addressed in the fee schedule or in the proposed fee schedule, but keeping an eye on that. Then obviously therapy cap and the exception process. So, new cap amount, the current exceptions process, as you know, we got a big repeal from a year or so ago with but guess what? That expires at the end of this year. We'll talk more about the ongoing legislation to completely repeal the cap, but they're more than likely in the fee schedule, we're not going to see a new exceptions process into 2018. We may get a new cap amount or estimated amount, et cetera. And then obviously the ongoing targeted manual medical review, going over the threshold, et cetera. Those are things we may see. So what may not be in there, or what's critical? So one of the questions a number of people ask me is, okay, we have these new eval codes and new re-eval codes, right, and the various complexities. In PT and OT specifically, and we had the new re-eval. but they all had the same RVU, right? Doesn't matter if it's what the reeval had a RVU adjusted, but the eval codes all had the same RVU. So regardless of which one you pick, we're basically getting compensated the same. So someone would think that since this went into play that maybe we're now going to see tiered RVUs. Highly unlikely. And the reason is we know how long it takes CMS and Medicare to get data and analyze data. So it's only June. If it takes them 2 years to take PCRS data or MIPS quality data from one reporting period to that, there's no way they have enough data or haven't had enough data to do the analysis to recommend any of these changes. So we don't anticipate the RVUs on the new complexity codes that we had to start using in January 1st, 2017 to change in this proposed fee schedule. Anything's possible, but it's highly unlikely, so you can maybe breathe a little easy there. Other surprises, we're really not expecting any significant new big surprises or things that come out of left field into the new fee schedule or the proposed fee schedule we'll see in the next 10 days. So hopefully that's good news, but stay tuned, and as soon as it comes out, we'll make you aware. I'm planning on scheduling, we have a webinar you'll see later on in August where we're going to do an entire webinar dedicated to what's in the proposed fee schedule and how do we best prepare and what does that mean and which items will impact us the most and which items do we need to prepare for, because more than likely they will be in the final rule in November. So keep on the lookout for that. As I said, we expect it to come out sometime between now and the 10th of July. So we'll keep you posted. So let's talk about a little bit some news from the Hill and all the things that are going on and exciting up on the Hill. It's hard not to talk about this, which is the American Health Care Act, House Rule 1628 that is currently in the Senate. And the Senate's given it its own name, the Medicare Reconciliation Act, right? So obviously the latest thing in the last couple of days is Mitch McConnell came out and told everybody they're delaying the voting until after the July 4th recess. Quite honestly, that from everything, all the pundits and news, whether it's Fox, CNN, whatever you listen to, they don't have the votes needed, right? So they're delaying it, and I don't know if delaying it's going to help them get the votes needed. There's a fair amount of concern about this from our perspective. Regardless of where you politically lie, there are significant cuts to Medicaid, which impacts the patients we see, right? A number of the patients we see. How that is going to play out. The CBO, the CBO released its score on Monday, and there's great. You could say, oh, look at the deficit cuts, over the course of the next 9 years, 321 billion. That's great, but we increased the number of uninsured by 22 million, not to 20 million, but we increased the number of insured by 22 million, which we almost double the number of uninsured. With this plan. So there's the link to the CBO report if you want. I also added the link to Sharon Dunn's letter, president of APTA, to the Senate regarding the American Health Care Act. And I think it's really important to read because it really, there's the personal thing is what does this mean to me as a person in using healthcare and healthcare for my family, et cetera. But from us as providers and our business and our practice, what it means to physical therapy and occupational therapy, as a discipline to provide care, there's a really good, it's eye-opening that I think I really recommend everybody reads that, whether you're in an alignment with it or not. I think it's a very well-written opinion that was sent, and I really recommend you looking at that. Other good things, so the therapy cap repeal, right? We talked about let's get rid of the cap. So the Medicare Access to Rehab Services, which is H.R. 807 and the Senate Bills 253. It was introduced in February. It now has 163 sponsors, so in the House, which is great, and 26 in the Senate. So more than half of the Senate sponsored. So we're really hoping this continues, right? This would be great if this thing could move forward. It's obviously probably not a priority with the repeal bills on the American Health Care Act, but that's definitely, it's gaining momentum. And there's some significant cost savings that this brings the government, et cetera, with repealing the cap. So keep posted on that. I track those things. You can track them on Twitter, the bills themselves, to see if there's updates or whatnot. This would be something that would alleviate a fair amount of burden from us across our practices. So the Connect for Health Act, it was introduced on May 19th. It's got 11 co-sponsors in the House and 13 in the Senate. This allows the PTs to use telehealth. So we kind of got carved out of the whole telehealth component. And if ever there was a benefit to be able to provide, I mean, in some ways, sometimes we're even doing telehealth today, we're not realizing it, right? So this is, I would really personally like to see this really gain momentum, because I believe this really provides really good quality services we can provide at a much lower cost to our patients with pretty good outcomes. So continue to watch this one. Hopefully this again will start to gain momentum as well, but this has pretty good impact. This will have a significant impact for us, particularly in the years to come, with the amount of technology changes that are occurring, and our ability to provide services sort of remotely will be key, and us to be able to participate in that will be fantastic. The Lymphedema Treatment Act, it was introduced in February. It's got a ton of support, right? So 242 sponsors in the House, 28 in the Senate. This bill is really good. It's hard not to support this bill. You know, when you look at the type of patients you're trying to be that are being impacted and suffering from oncology-related things, you know, the ability for us to provide Medicare coverage for the supplies, the garments, the bandaging, all the things that we need to effectively treat patients with lymphedema. While I practice, I did quite a bit of lymphedema treatment, so this kind of hits home with me. Maybe that's one of the reasons I added this one in here. But it's hard not to support this one, and you keep on tack with this. So if you have programs where you're doing a fair amount of lymphedema or cancer-related treatments or oncology or women's health, et cetera, this is one we want to keep an eye on that we'd love to see get some significant momentum and get passed. The other one that really kind of caught everybody off guard is, you know, the whole TRICARE thing, where, you know, they came out and, you know, with DOD, et cetera, and kind of just basically carved out PTAs and CODAs. And so this is an ongoing battle and fight to get, you know, therapists recognized as other than paramedical professionals. So, you know, and looking to be able to get appropriate recognition under their program, and then specifically change the sections and chapters where and in their policy manual, so that, you know, we can get PTAs and CODAs, you know, covered by the services they're rendered. This just does a big disservice to their beneficiaries, right? It impacts us, but significantly does a big disservice to their beneficiaries as well, and trying to get them to see that. So both the AOTA and the APTA, your associations and organizations, are actively fighting and pursuing this and working through these channels. So keep posted on this one, because again, this one has significant impacts as well. So now let's talk about something that's not so nice. Not that all that other stuff is pleasant, but you know, it's kind of the dark web, all those crazy TV shows and movies we watch, all of a sudden some of this stuff's becoming a reality. So ransomware and malware, the impact, pretty significant across the board. The biggest thing I want everybody to know on this phone is none of the attacks, whether the attack in May I'll talk about, or the attack in June, just on Wednesday that came out, or Tuesday that came out, none of these are specifically targeting healthcare. Healthcare is kind of a fallout of it, but it's just going after technology and big data systems. And so, you know, you tend to hear, or we tend to sometimes hear things through the context of, oh my gosh, healthcare. Well, healthcare was impacted by it, but that's not the target or focus. And a number of cybersecurity sessions I've attended by some of the top cybersecurity people out of San Francisco, and that are managing and watching this and tracking this stuff, and even the government themselves will tell you that. So those kind of the more famous things, or famous ones that have happened, was the WannaCry or WannaCrypt on May 13th. So it occurred and happened very, very fast. So it very quickly spread to 105 countries, over 200,000 plus computers. This was all in a window of hours or days that occurred. Again, it wasn't a healthcare attack. They primarily went after all of the most vulnerable systems that existed in Europe and in what I sometimes call the second world, developing European nations. And all those industries that really they exploited vulnerabilities where they hadn't spent money on technology, infrastructure, updating systems, updating security systems, and that's where the bulk of the impact came from. And so, again, it wasn't a healthcare attack, but healthcare entities were impacted. Not very few, if any, vendors who provide healthcare technology and services were impacted at all, but a number of like small hospitals or hospitals who, again, maybe haven't completely updated their systems, haven't provided all the Microsoft patches and security patches to their servers, etc., were left vulnerable. And because this is something that's going to continue to occur, these are not isolated events, because there's technology and systems out there that have been exposed where people are leveraging this. This little screenshot you see down below where it literally says, oops, your files have been encrypted. This is an actual screenshot from what somebody saw on their screen when they got attacked. You got this amount of time to make payment. Your files will be lost on this date. It counts down. It tells you where to put, how much money to put in, pay by Bitcoin, etc. And then they provide you a key to open up to allow you to decrypt the system. The first attack, this one, the WannaCry or WannaCrypt, was pretty rudimentary from technologists. Somebody found a kill switch and was able to stop it. There was a whole bunch of code errors, and so it was kind of a hack from a hacker. It wasn't really sophisticated sort of thing. So that's a good thing. But this one, this week, wasn't. One of the big differences that some people noted is, oh my gosh, this one, what it was called Petya or not Petya virus, was another ransomware attack, another attack that was not specifically targeted to, to healthcare, and you'll see that. But there was a couple of systems, Heritage Health Valley System in Pennsylvania got hit pretty hard. Nuance, who some of you know as Dictaphone, or the big cloud-based provider of digital dictation for the physician systems, they got hit really hard, including Merck, pharma giant, got hit pretty hard. It goes to the internet, and there's a number of different things that it impacts. So we got to be aware of these things, protecting our system, protecting our data. So what can you do about it? I'm going to talk about that. But on the Petya, and this was very similar sort of where they attacked. So in this particular one, they went after the country of Ukraine and its vulnerabilities like crazy. You can see the U.S. is way down there. So they went after their infrastructure, their banks, their airports, their power grid. It went after all of those systems because they had basically not done some of the things to do to help protect themselves. So what can you guys do, talking to your vendors, talking to yourself, if you host your own systems, etc. So make sure all the Microsoft patches are deployed and updated. Ensure you're running all current software systems. So if you're running Windows XP, that is a non-supported operating system that is not patchable. Microsoft actually put a patch out for the WannaCry, but they weren't required to because it is blatantly end of life, end of support. So you got to make sure your technology group staying current. You got to advise all your users, make sure you have business associates agreements in place. Educate your people on phishing attacks. One of the big ways this spreads so pervasively is they get in through email, through the internet, and they'll send an email from somebody in your organization posing as that person to you with some attachments. And if you open that up, you start to proliferate it. So you really got to be teaching and educating your staff as to something looks suspicious, and a lot of education needs to go on, be able to help do that. Again, make sure you've got really good testing and data backups. If you're backing up your data, or you have a partner or a vendor who's backing up the data, you need to be asking them about, do you back up your data, or do you actually back up your data where you could recover from it? How long would it take you to get us back up and running if everything was down? What kind of disaster recovery do you have in place? You need to start asking those questions, because when it happens, it will have significant. And they need to make sure you as an entity have insurance for and coverage for that specifically. So quickly get into some additional regulatory updates. Let's get off that bad dark web stuff. So the Physical Therapy Licensure Compact, kind of exciting stuff. We needed to get 10 states on board. Allows, from a license perspective, to potentially practice in another state without having to go get licensed in that state. This is great for contract therapists or traveling therapists, home health. It's a really good thing. Be watching that. There's a link there. You can go get more information on it. It sort of officially became enacted on April 25th. There's a little background with color codes as to who's enacted the legislation, who's still looking at it. It's kind of state-driven by the federal state board, so that's a really good thing. More of a heads up, new Medicare number, right? So new Medicare number is coming for all beneficiaries. There's some good links there. New Medicare cards are going to be mailed out with these new numbers. Make sure you're prepared on your billing system, your clinical system. Your vendors are preparing or managing this, because this could be somewhat disruptive, could impact claims, etc. There's a good link to the provider page there, and some of the transition education. I'll be continuing to talk more about this as it's coming in April next year. And then again, really good. I feel like I'm promoting APTA a lot, but there's really some great stuff from an advocacy perspective. And so yeah, every couple of years there's a policy document that's put out. I put a link to it, their priorities, as we're moving to quality-based and value-based care, medicine, et cetera, because of a number of different things. You just read that. It's really, really informative, and I think you'll find it of value. Real quickly, as we're wrapping up, I know we're kind of getting up on time here. So additional webinars, I mentioned this before. The physician fee schedule update, we're going to do August 17th. We'll do a full analysis of the new fee schedule that comes out, or the proposed schedule. What does it mean, the impact to you, et cetera. Our Q3 regulatory update, just this one for Q3, is October 5th. We moved that date, so if you have a previous date, you can get signed up for that. We'll make sure you keep you aware, and you'll see us through social and through a number of things. And then right now, the date for our Q4 one is December 7th, and obviously we'll have the final final rule for physician fee schedule and a number of things we'll be able to prepare you as you head into next year. Some things for us. We're having a customer conference in Las Vegas on the 13th to 15th, so if you're a client and you're attending right now, be sure to be asking about that, or ping Megan or any of us. We're excited about that. It's going to be a great two-day event we have going. A couple of the conferences we're attending, the NHPCO conference in San Diego, NARA fall meeting, the ACA and NCA annual convention in Vegas. It's a big one, and the private practice section will be in Chicago. I think by the end of this, we'll all be tired of Vegas, because I see Vegas on here 3 times, but it should all be good. And then quickly, resources. I won't go through all these, but here's a lot of the references. I got a few more I've got to add, update this for you. But again, this is the source of truth. Please use these for making definitive determinations, etc. And so with that, I'm going to hand it back to Megan to kind of wrap us up. I appreciate your patience. I know we went really fast, but a lot of content to cover, and I want to be conscious of just taking an hour of your time.
Thank you, David. Just to wrap up quickly, as a reminder, we did record today's session, and you will be receiving a link to view it and share it in an email tomorrow. We'll make sure to include a PDF copy of the presentation, so you have links to those resources like David said. Again, we invite you to join us for our Q3 update, and especially for our special session that will cover the physician fee schedule. We're planning that for sometime in August, and we'll include that in your email as well, a link to register. So if you want to follow us for more updates, you can join us on our social channels. We're on all the major channels, and David has his own Twitter as well, at D_McMullen. We unfortunately ran out of time for questions, but I do have copies of everything that was asked, and we'll make sure to have somebody from Casamba follow up with you directly to get those answered. Again, thank you so much for joining us. Thank you for your patience, and we look forward to having you next time. Thanks again. Have a great day.
Thanks, everyone. Happy 4th.